innovation in association and supported by Viatris. So thank you very much indeed for coming. My name is Jackie Thornton. I'm your moderator. I'm a journalist in the UK for The Lancet, Nature and the BMJ, and I've been writing about the gaps in cardiovascular care for women for a long, long time. And why is this not changing? This is what we're going to explore today. It's a really, really important topic, and I think it was really brought home to me yesterday. In this very room, I was moderating a completely separate event with experts, like my panel today. And one of the people was a woman physician, a leader in her field of primary care, but quite coincidentally, she also revealed within the session that she herself had had a heart attack. And I'm going to leave the medical side and the scientific side to people much more experienced than me, because that's anecdotal, but it just really brought it home. This is around us here and now. Women are suffering, and they needn't do. What can we do to close those gaps? So without further ado, we've got a, as I say, we've got a packed schedule in the next hour and a half for you. So I want to introduce the World Heart Federation's Vice President, Professor Aman Mbekwe, who's going to explore will frame it for us as to the issues and challenges. Thank you very much indeed.
So good morning, distinguished delegates, esteemed members, everybody who's come to join in this clarion call to improve the cardiovascular health for women. It's my great pleasure to welcome you to this side event, Women and Cardiovascular Disease, Closing the Research, Awareness and Care Gap. Cardiovascular disease remains the leading cause of death globally and amongst women. In particular, it is responsible for approximately 1/3, 1 in 3 deaths among women every year, and claims more women's lives than all forms of cancers put together. Yet, despite the immense burden, women continue to be under-recognized, underdiagnosed, undertreated, and underrepresented as people living with cardiovascular diseases, as participants in research, as healthcare professionals, and as leaders in public health. This is not only a clinical issue, it is an equity problem. Despite progress in advancing gender equality in health, significant inequities persist for women, including in heart health. Too often, cardiovascular disease continues to be perceived, researched, diagnosed and treated through a lens that does not fully reflect women's symptoms, risk, lived experience, and needs. For decades, much of the evidence guiding cardiovascular prevention, diagnosis, treatment, and care has been derived primarily from studies conducted in men, and we are supposed to be extrapolation of that data. To date, women remain underrepresented in cardiovascular clinical trials, accounting for only 38% of participants, with even lower representation in studies on heart failure, coronary artery disease, and stroke. But I want to shock you that the figures are even worse when we consider women of color and those from low and middle income countries. Closing the gap will require concerted action on all fronts. So we all have to collaborate. First, we need to strengthen the evidence base. This requires a systematic inclusion of women in clinical trials, epidemiological studies, and data collection. It also means embedding the routine collection, analysis, and use of sex and gender aggregated data across research, and not just post hoc analysis, because that's what happens with those big trials. After the data, we analyze as post hoc. So that needs to change. We need to sit on the table from the onset, from the time the research is being thought about. We need to sit on the monitoring team. We need to be part of the research. And that's the only way we're going to close the gap. Second, we need to ensure that cardiovascular diseases is explicitly addressed within gender and health equity initiatives. Women's heart health should not be considered a side issue or a specialist concern. It must be embedded in national health policies. Thank God we have a minister here today. Health system strategies, regulatory frameworks, and broader efforts to advance the substantial development goals. Third, we need stronger awareness and education. Women, communities, healthcare professionals, and policymakers all need accurate and accessible information on cardiovascular diseases. We must improve recognition of symptoms and risk factors, address gender bias, and support women to both seek and receive timely and appropriate and high-quality care. I just pause a bit here. I'm interested in heart failure, and I work a lot with peripartum cardiomyopathy. A woman has a baby and develops peripartum cardiomyopathy. Nobody takes her seriously. Oh, she's just, it's postpartum blues. Oh, she's just tired. Oh, she's too lazy to look after the baby. Until it's too late. That shouldn't happen to any woman. Fourth, we need to advance women's representation and leadership across and beyond the health sector, including in research, healthcare delivery, public health, policymaking, and governance. Women's participation and leadership are essential for equity and for more gender-responsive care. Today, we'll hear from leaders across the globe, research, policy, clinical practice, and civil society. Today, we'll highlight gaps as well as solutions that are within reach. I am confident that our conversation will help move us from recognition to action. In particular, closing the gender gap in cardiovascular health will require more than awareness. It will require investment in research, gender-responsive policies, stronger health systems, better data, and sustained accountability. Most significantly, it will require us to listen to women. Let's hear their stories. Let's hear their stories. Let's hear what they're saying. Their stories may be different from that of the men, but let's hear them. Let's listen to their symptoms, their experiences. Their priorities usually are different from that of the men, but we don't look at them that way. They are just the numbers that make up the statistics. But that's why we're here in this room. That needs to change. So the World Health Federation remains committed to collaborating with member states, the World Health Organization, and all relevant stakeholders to advance gender equity in heart health. At the World Health Federation, we say no heart should be left behind. But this morning, I'm saying no woman's heart should be left behind. Addressing women's health is essential to our mission of achieving cardiovascular health for everyone. So before we start, I'd like to express our sincere gratitude to Beatrice for supporting our event and bringing today's conversation to life. I'm now pleased to hand over to our able moderator. If you've listened to her, you know she's capable, she's able, and she'll make it very lively to guide us through this event. Thank you for your attention.
Thank you very much indeed, Aman. And I think that, having moderated at the World Heart Federation for some years now, I'm always taken by the really impressive, strong women that I meet at the summit and here at the side meeting. So, I think with those voices, we're going to get there. I'm going to hear some more very strong voices on the panel. But it's really important also to have male allies, advocates who can help. And I'm very pleased to see there are lots of men in the audience, but also, we have Senator Dr. Kenneth Connell, who is president of the Healthy Caribbean Coalition, a friend and member of the World Health Federation. Now, the coalition is an alliance of over 100 health and non-health civil organisations fighting against NCDs. So, Kenneth, your presentation, please. Thank you.
Thank you so much, Jackie. And I know how strict you are with time, so I will stick to time. So, I feel as if, coming from an island like Barbados, I am genuinely qualified to wish you all a very warm meeting here in Geneva. And I recognize I'm the only guy on the panel, and it totally occurred by accident because the minister was meant to be No, I'm not a guy by accident. The minister was meant to be here, and our minister is actually a woman. But I'm very glad to be presenting, I guess, on the male voice here, because for my entire career in internal medicine, advocacy, and now in politics, I have really been advocating for equity for women in cardiovascular health. So officially, distinguished colleagues, excellencies, representatives of the World Heart Federation, partners in global health, gentlemen and ladies, good afternoon. I bring you warm greetings from Barbados, a big ocean state in the Caribbean. I didn't say small island. It really is an honor to join you here in Geneva during WHA and to participate in this important conversation on women and cardiovascular disease, closing the research, awareness, and care gap. If I could just start with a story. When I started medical school in '94, there were even the description of cardiovascular disease in the textbooks that were being used, there was no mention of women. In the emergency room, coming in as a medical student, I saw cases that I could tell were being treated differently. Women who came in, usually not as dramatic as men, because you know men, when we get sick, we're dying. They were placed in a waiting area for observation, whereas men were shuttled straight to stat room, even if they said, I just don't feel well, kind of thing. So that has occurred. Over the years, I now have the opportunity to see medical students who I like to hope have left the impression that there should be no bias. But I know inherently there is a bias, and I see it every day. Just to use an example, in my country, women wait on average 12 minutes longer to have the initial ECG in the emergency room. 12 minutes longer. And it's not just a man-woman thing, because most of the people doing the initial ECG are women. So there you go. It really is an honor to join you here. And I speak today not only as an academic physician and hypertension specialist in Barbados, I'm president of the Healthy Caribbean Coalition and a member of the NCD Commission, but genuinely as a person who has cardiovascular health of women to heart. Across the Caribbean, and really indeed across the world, we are confronting a profound contradiction. Cardiovascular disease remains the leading cause of death among women. Yet women's cardiovascular health continues to be under-recognized, under-researched, underdiagnosed, and too often undertreated. For decades, cardiovascular disease has been framed consciously or unconsciously as predominantly a male disease. The consequences of this misconception are measurable. Women are less likely to be enrolled in cardiovascular clinical trials, less likely to have symptoms recognized early. I mentioned the ECG. Less likely to receive aggressive risk factor management. You know, you're only a woman, these are menopausal symptoms. They'll go away post-menopause. And in many settings, less likely to receive timely evidence-based treatment. This isn't really simply a clinical issue when you think about it. It's a systems issue, a research issue that needs to be disaggregated, a policy issue, and fundamentally an equity issue. The Faculty of Medical Sciences at the Cave campus in Barbados, where I work, is right next door to the Institute of Gender Development Studies. I never thought there would be cross-fertilization of thought between the two institutes, except that they make much better coffee and I go over there. But really, this looking in detail at what are the barriers, what are we doing in the health system that just isn't right? Studies from large international registries have shown that women with ST segment elevation, MI, often have longer door-to-balloon times and higher short-term mortality compared to men. Similarly, in stroke, women are more likely to present later, less likely to receive acute interventions in some settings, and often experience worse outcomes and longer disabilities. Remember, these are the women who are the backbone of our society, who are in some cases single parents, who are the earners and keep the family matrix in order. And importantly, women remain underrepresented in many landmark cardiovascular trials, which we cite and which we have developed our evidence-based interventions, despite the established cardiovascular burden. This matters because evidence generated predominantly in men does not translate perfectly to women's biology, symptom patterns, pharmacology, and even risk profiles. Quite recently, in my own private practice, I wondered whether I had a bias in the way I treated men versus women. And secretly, my secretary audited the time I spent in conversations and highlighted to me, and this is just because it's between the two of us and this isn't a live stream, that you spend longer with your male patients on average by about 4 minutes. So this is significant, and I have had to check myself to see what I'm doing wrong, whether that bias exists. First, we must strengthen cardiovascular systems of care with explicit accountability for women's outcomes. Universal cardiovascular care is insufficient if women continue to experience worse recognition, delayed diagnosis, and poor outcomes. We must improve cardiovascular training at both the undergraduate and postgraduate levels. This is where I'm wearing an academic hat. I'm glad to see that there are references to women with cardiovascular disease. I'm one of the exam question writers for my own university, and I've had to secretly or otherwise reconstruct questions so that they're presenting as women with cardiovascular events. We also need to represent women differently. Chest pain may be atypical, but if half your population has that type of chest pain, why is it called atypical? Symptoms may be dismissed as anxiety or stress. Hypertension risk may be underestimated in younger women especially. I've noticed this bias with residents in my own hypertension clinic, where women are often told, you just need to relax more, don't let your husband stress you out, and you'll be better. So the delay in instituting medical management is there. Our systems must evolve beyond outdated assumptions, but we need to measure what those assumptions might be first. We also need integrated national pathways of prevention, diagnosis, rehabilitation, and chronic disease management for major cardiovascular conditions, including hypertension, heart failure, atrial fibrillation, ischemic heart disease, and stroke. Importantly, these systems must measure outcomes properly and in an unbiased fashion. If we do not routinely collect and analyze sex-disaggregated data, we cannot identify inequities, and we cannot correct it. Small island developing states or big ocean states are especially at risk for this because many of us are still not using electronic medical records, and therefore, if we're not counting it, the assumption made is the inequity isn't there, and that's incorrect. What is measured remains visible. Second, we must recognize pregnancy as one of the most important cardiovascular risk assessment opportunities in a woman's life. Pregnancy represents a physiological stress test. Conditions such as hypertensive disorders of pregnancy, including hypertension, including preeclampsia, gestational diabetes, preterm delivery, and preeclampsia, are not isolated obstetric events. Quite often, half of my clinic are women, and half of those women are women referred from the obstetricians. And this comes with education. It wasn't always easy convincing my obstetric colleagues, this isn't just hypertension in pregnancy that once delivery happens, you can do a 6-month follow-up. This patient is high risk and needs to be referred. These are cardiovascular warning signs that women present to the health system and have potentially will be missed if we don't follow up. Globally, many women complete pregnancy and disappear from cardiovascular follow-up, and this is a major missed opportunity for prevention. Women with pregnancy-related complications should enter a structured long-term follow-up pathway that include cardiovascular risk screening, blood pressure monitoring, lifestyle interventions, and preventive cardiology. Obstetric and cardiovascular care can no longer operate in silos, and this is important. The future of women's cardiovascular health depends on integrating maternal health into a lifelong cardiovascular protection. Thirdly, we must elevate sex-specific cardiovascular research and surveillance as national and global priorities. In Barbados, we deeply appreciate the value of high-quality surveillance systems, including the Barbados National Registry. Registries and surveillance systems help us understand disease burden, treatment of gaps, and population outcomes. But data must be intentionally analyzed through a gender lens. And I want to say that want to repeat that. Data has to be intentionally analyzed through a gender lens. This is where my colleagues in the Institute of Gender Development Studies often say to me, remove your lens. Now I can't see you. And it has to be seen through a gender lens. When disparities are identified, they must drive targeted policy interventions. It's not just satisfactory to publish the results. The absence of evidence in women cannot continue to be interpreted as evidence of absence. The Global Hearts Initiative, Taskeen and now Hearts 2.0, represents a major opportunity to strengthen cardiovascular prevention and hypertension control worldwide. But we must ask these very difficult questions. Are women screened equitably? Are younger women being appropriately risk stratified? Are pregnancy-related hypertensive disorders being incorporated into cardiovascular risk assessment? And are there structural barriers preventing women from accessing ongoing hypertension care? Because even strong public health programs can unintentionally reproduce inequities if gender gaps are not actively examined. Hearts 2.0 therefore offers an opportunity not only for improved hypertension control, but to modernize cardiovascular prevention through a more gender-responsive lens. Cardiovascular disease does not begin in hospitals. It actually begins in communities. It is shaped by poverty, education, urban design, food systems, employment conditions, chronic stress, including husbands, and unequal opportunity. If women do not have safe environments for physical activity, equitable economic opportunities, access to healthy food, or time to prioritize their own well-being, our prevention strategies will all fail. We must therefore build societies that make cardiovascular health easier and not harder for women. This includes investing in safe and accessible opportunities for physical activity for girls and women across the lifespan. It means recognizing structural realities and caregiving. Colleagues, closing the cardiovascular gap for women will require more than awareness campaigns. It will require structural reform, it will require research reform, it will require accountability, and it will require political courage. But the rewards will be enormous. Healthier women mean healthier families, healthier communities, and healthier, to the politicians, economies. The science is already telling us what we must do. The question before us really now is whether our systems, policies, and political leadership are prepared to act with sufficient urgency. Women should not remain invisible within the world's leading cause of death. And future generations should not look back and ask why the gaps were allowed to persist for so long when the evidence before us was already so clear. Thank you very much and enjoy your meeting.
Thank you very much indeed, Kenneth, for that great talk. And I, take an awful lot from what he says, but some of the things were, that word atypical. Why atypical? Crikey, why can't we be more human about this? And also, he reflects on the time spent with men versus women in the clinic, which is interesting to me because I've always, throughout my health journalism, thought that men don't want to come forward. So it's ironic that actually, when it comes to it, they get more time spent on them when women actually are better at talking. So just my own personal reflections. But I now want to introduce Dr. Barrett Jeffers. Dr. Jeffers is a cardiologist by background. He's now Global Cardiovascular Medical Affairs Lead for Viatris, our sponsor. So thank you very much indeed to you. And he's going to do the science bit, I think, and explain a bit more in detail about MI in women. But thank you very much indeed, Barrett.
Great. Thanks, Jackie. So number one, welcome everybody. Pleasure to be here and honored to work with the World Heart Federation in such an important topic. I kind of want to take a step back and bring some of this to life and do that via heart attacks. Okay, I grew up and basically growing up was told we have a horrible family history of cardiovascular disease and people die of heart attacks. Guess what I heard? Your dad died, his dad died, uncles died, etc. Closer inspection, guess what? My mom died of a heart attack. Both of my grandparents, female died of heart attacks. One of the grandfathers did not, by the way. So 3 of the 4 did, 2 of which were the women. Aunts died of heart attacks as well. But we never talked about that at all. And that's proliferated, kind of throughout. And it's really important to bring that to life here. So I'm going to kind of focus in quickly. Again, Beatrice, we're fairly new. We started as a company 5 years ago. Our mission at Beatrice, as you can clearly see here, is just to empower patients worldwide to be healthier at every stage of life. And that definitely includes from a cardiovascular perspective. And what you can see, my slides keep disappearing. It keeps going to the red slide in between. I can skip that slide and I'll just go to the next one since it doesn't want me to talk about that slide. So with that being said, I kind of want to bring it back to heart attacks. We know that cardiovascular disease is the #1 killer in the world. We know that's for men. We know that's for women. Okay? We know that heart attacks, they occur in all people. It's not a disease of elderly men. Okay? This is a disease of all racial, ethnic groups, ages, and genders. And we need to make that clear because it's not clear today. And you can clearly see that this is not a completely problem that's devoted to certain regions. It's not just lower middle income countries. This is happening in the developed world as well. And you're going to see a lot of focus around specific areas. But we need to bring all of that back and really open this up and discuss what's these problems and how we can truly address these problems. Even something as simple as the average age of a first heart attack. Some people will look at this and say, that's similar. It's happening in both women and men. Others will look and say, look, it's a little lower in the men, so because they're at higher risk. That's not the messages that we need to get out there. And if you think about that, think about what happens when you have a heart attack. You're out here, you have some symptoms. Okay? What do you do? When do you act upon those symptoms? That is one of the things that we really need to address, by the way. We heard from Kenneth what happens once you make it into the system and through the hospital and being the triage, etc. But what will happen is you have to identify, gosh, I think I might be having a heart attack. When I talk about stroke, it's pretty clear what the symptoms are. When you talk about heart attack, I could ask each one of you in this room, and we're not going to get the exact same symptoms of what a heart attack is. Chest pain, excessive chest pain. What's excessive? What about shortness of breath? What about fatigue? What about nausea? Those aren't symptoms of a heart attack. They are. And this is one thing I always say, and this really brings it home. Doubt, I consider a symptom of a heart attack. If you don't think you're having one and you're doubting it, because you'll come up with everything in the book about explaining the symptom that you're having. From I was gardening too much yesterday, so this must be something I'm feeling from them. That's not what's going to help us. We need to act upon these things because time is what's vital. Throughout this whole thing, women and men follow the same thing through here, but they follow it at different times. Women actually are much slower to recognize symptoms than men are. So number one, they're coming up slower before they even present to the hospital, which is a major, major issue. So for example, a third of the patients, they die before they get to the hospital. So they never even made it in to be treated. And even then someone did, another portion died within 30 days. You're talking 40% of the patients. That's telling you how important time is. And you got to act upon that at the appropriate time. Because if you look at clinical data, you can clearly see, and there's a scientific Explanation, very platelet-rich environment early. As the heart attack gets further, the platelets convert to fibrin, very difficult to treat close. And then you can see clearly a correlation, time, mortality. You wait longer, you're much more apt to die. And women are waiting longer. So if you think about that, why do women wait longer? There's misinterpretations of the heart disease symptoms. They're not educated appropriately on what those symptoms are. So what you'll see is up to 3 hours, even days in some individuals, depending upon, the symptom, because, you'll be getting symptoms very early, and then once you have a full-blown heart attack, of course, then time really matters, because any damage done to your heart is permanent. And then that puts you at higher risk for heart failure and all other types of things later. So it's really important that we talk about how we can address this issue that we're seeing within women. And if you look at like the European Society of Cardiology, look at their ACS guidelines, they clearly show all of the data and stuff out there pertaining to risk factors are different in women. They present more with hypertension, CKD, diabetes, smoking. Those women are impacted more by those diseases and their heart attacks than men are. There's also specific risk factors for women. So for example, premature menopause, risk factor. We don't talk about all of these as much, and we need to. And we need to educate within that. The biology is different. There's differential diagnoses that we just heard about as they kind of go through, which all leads to worse outcomes. So in conclusion, what can we do? There's a lot we can do. Okay, so it's a big call to action. I get that here. But risk assessment and prevention. Implement gender-specific cardiovascular risk assessment tools. We're not very good at doing that. We're not very good at even using any risk assessment tool, but when we do, it's just one. And we don't really discuss the gender appropriateness of that. Address the modifiable risk factors, hypertension, diabetes, smoking, obesity. We're pretty good at talking about risk factors with patients. As cardiologists, what we're bad at is discussing symptoms of a heart attack and the need to act. If you have a heart attack and you're lucky to survive and you talk to your cardiologist, they're going to say you need to be on drugs A, B, C, D, and E. This is the reason why. It's going to reduce your chances of having another heart attack because you're at risk for another heart attack now. And they're going to do all that discussion around the risk factors. They're not going to talk at all about recognize your heart attack early if in fact it happens, because they don't want to bring up the negative aspects of that. They just want to say, hey, you can reduce your chances. We got to change that thinking and that narrative, and that's one way to do it. Promote awareness of the non-traditional risk factors that are far more common in women. For example, autoimmune diseases, hormonal changes, etc. These are things that typically we're not thinking and acting upon. Recognize the symptoms. It's not just training patients, it's training clinicians, the public to recognize the symptoms, and especially the atypical ones in women: fatigue, nausea, back, jaw pain, shortness of breath. Those are symptoms that are very common. Okay, so we need to make certain that everyone's aware that these symptoms lead to increased risk for heart attack. Sex-aware triage protocols, as we just saw from Kenneth's discussion. We really need to look into this. Early diagnosis and treatment. Ensure rapid access to diagnostic testing. Apply sex-informed treatment guidelines for revascularization pharmacotherapy. Address disparities in access to care, especially in the underserved and rural areas. Why? Guess what? Underserved rural area, what happens? It's slower. The time increases. We've seen what the impact of that is going to be. And it leads directly to higher mortality rates, kind of within those areas. Rehabilitation, long-term care, provide gender-sensitive cardiac rehabilitation programs, integrate mental health support, especially within women. Depression and anxiety are much more common in women when they post-heart attack. So we need to take that into account as we're doing all this. We always encourage lifestyle changes, risk factor monitoring. We still need to do that, discuss its importance. And then, of course, we need to fund sex-specific AMI research to better understand the outcomes in pathophysiology. And at the same time, as Kenneth mentioned, we need better representation in clinical trials, and research, and then bring that, kind of to life. So with all of that, I mean, I think we can, if we work together, and it takes all of these groups, not one can do it in isolation. If you're not involving the patient, it's not going to have the impact that it could have. We need everybody's voice to be heard. And with that, I thank you, and this next panel is going to be an incredible discussion, and looking forward to it. So thank you very much.
Thanks very much indeed, Barrett. That was great, and it's your talk so complimented Kenneth. So really great to hear all of this. And I wonder, could we keep the call to action slide up? Because I'd like to refer back to that later on, and that'd be great. So, yes, we have got a great panel for you. I don't want to fall off the edge of this stage. Also, in terms of what Barrett said, in reminding of my own personal history, and I don't really think about it because it was such a long time ago, but my maternal grandmother died of a heart attack at 68. My mother's got high cholesterol. She's probably, at risk too. So, yeah, I mean, it affects so many of us. So yeah, we've got a lot of information to get to grips with in our discussion. I want to introduce my panel. I have Dr. Alia El-Yassir, who's Acting Director at the WHO Department of Gender, Diversity, Equity and Human Rights, and for many years previously was at UN Women. So if you could join us on the stage, that would be great. We also have Anouk Peterson, Director of Women's Health at the McKinsey Health Institute. She's also author of the Blueprint to Close the Women's Health Gap, How to Improve Lives and Economies for All. So welcome to you. Oh, my thing's just gone off. We have Dr. but I'm not going to give her lots of medical questions, Dr. Tazkeen Khan, Director of Health Research and Content at the World Innovation Summit for Health, WISH, part of the Qatar Foundation, and previously you'll know her as the technical lead at WHO. Why don't you can go over there. Okay. And we also have Dr. Tiffany Dove-Abam, who is the Chief Executive Officer of the Dove Foundation for Global Change. This is a grassroots initiative which initially focused on education and employment and entrepreneurship for young women, but actually, and that was in West Africa, but now it's expanded into health because they saw that health was such an important focus, which opened so many doors to so many other things and now works globally. So Tiffany, if you'd like to join us on the platform. So we've already covered an awful lot. How I wanted to split this panel was into the current situation, solutions in terms of advocacy, and solutions in terms of practicalities. Now, we have covered an awful lot of the issues before, up till now, so I don't want to repeat necessarily too much, but what I wanted to do first of all was for you to reflect on what we've heard so far. Is there anything that Kenneth and Anna have missed, and also Kenneth, is there something that you think needs to be added to the debate, or do you want to actually emphasise some of the things that have been mentioned? And the call to action, I mean, that's a really comprehensive, as Barrett says, it's pretty good. Which bits of that are the absolute go-to? So I just thought, Alia, I'd come to you first of all. I'm not picking on you.
Right.
But, what do you think, what do you reflect on what you've already heard so far? Is there anything missing, or is there anything that needs to be really emphasised?
Both.
Okay.
I think the evidence gap should not be underestimated, and the lack of representation of women is really something we need to look at, but also women are not a homogeneous group. So it's not just about adding women, but really trying to look at how diverse the groups of women are, because we heard from the opening remarks that you need to sometimes look at younger women, you look at older women, you look at women of color, you look at women in lower and middle income countries. Are they represented in these trials? So I think that's really important, but it's not just about the number or the percentage. We heard the percentage, 38%. Do keep that in mind. But it's not just about the percentage, because the data is not disaggregated. Even if they are represented, the data is not disaggregated and analyzed on the basis of sex.
Yeah,
So,
just spell that out for someone like me who's a Dumbo, in terms of what does that exactly mean?
so it means you include women in the clinical trials, but when you are analyzing the data, you're not looking at the differences by sex. So, exactly. And so I think I pulled out a number that, and this is not specific to cardiovascular disease, but when we look at studies across different disciplines, only 5 to 14% of those studies examine outcomes by sex. So it is important as a matter of principle to have representation, but if you're not making it a point to look at the data. So that means that clinical guidance, by the mere fact of only having 38% women, is already skewed towards male data. But then also we're building health systems based on male patterns of the disease, which is what we've heard. And so women's symptoms are likely to be missed, or they get treatment too late. But to that, why is this happening? And I think also the speakers have covered it, but I think it's really, really important to talk about structural inequalities. This is happening because these inequalities are so embedded. And this is linked to gender norms. We all carry them. I mean, even in the keynote, when you actually have to face the truth. Why are you spending 4 minutes more on average with men? It's because we're programmed, all of us. And so we carry that with us. So the final message, because I know you want to get to others, is please let's just think of add women and stir. This is not the solution. We really need to address the gender norms and really understand them. Because also these norms are playing a role beyond just how women are represented or are in clinical trials, or how the data is looked at. Because then you have to look at, for example, poverty. We can look at income poverty, but you also look at time poverty, right? And so caregiving responsibilities that are disproportionately borne by women and girls will affect their access to health services. So this, and I had seen a study that was done on care work, or different dimensions of care. And women do more care work in all dimensions except one.
Which is,
Do you know?
No.
Self-care.
Okay.
That's the only one where men outperform women. So this is really something for us we really need to keep in mind.
Absolutely.
And finally, that the social norms also can affect the acceptability, of care. If the majority of cardiologists are men, in some parts of the world, women will not feel comfortable, or it will not be socially accepted for them to seek that care. And that brings me back to representation. Why is it that only 15% or so of cardiologists, I believe, worldwide are actually women? Because even looking at representation in this field is going to be critical to tackling those gender norms.
Okay, well, look, thank you for those really good remarks. I want to ask all the rest of the other three the same, but obviously a lot's been covered in that. But Taskin, can you add anything from your perspective as to what we've heard so far? What resonated particularly with you?
So I'm going to tell you a little bit about language and a little bit about history, because it's quite interesting that when women present to emergency rooms with cardiac symptoms, it's often given the diagnosis of stress or anxiety, or misdiagnosed, as we heard, in the presentation. But the word uterus in Greek is actually hystera. And that's where this concept of medical diagnosis of hysteria was really originated from. And it was thought to be a wandering uterus looking around for, semen and fertility, and that's how it was linked. And that was only declassified in 1980.
No.
So this is very fundamental, I think, to understand the entire concept of medicine. It goes far beyond cardiology alone, and it sort of speaks to the fundamental and the structural inequities. Because if that's the sort of premise that you're coming from and you're working from this idea of hysteria as a diagnosis, then we can understand why many things get misdiagnosed. And
Let me stop you there, Tasmin. I mean, just having a 19-year-old daughter, I do find that the younger generation, I mean, she's not in healthcare, obviously, as a clinician or a practitioner, but I do find that the younger generation have an entirely different perspective to many of us. We, as you say, have lived with this for a long time. It's these norms. But do we see, is there hope for a change? I mean, I don't know. I mean, we've got you as a clinician, but not practicing at the moment. I mean, I'm throwing this open. I'm just wondering whether or not we see some sheds of light of the younger, cardiologists who are changing things. But that's probably too big a question for today. Carry on.
no, I think there's definitely hope for change. Because I think the new generation know what they want. Just in general in life, I find, girls today refreshing. They know how to set boundaries, how to stand by their boundaries, how to speak about things a lot better than I think I do even. And I think that, for me, the cardiovascular diseases, you have the clinical aspects and you have, the differences in physiology and things, but it also speaks to the policy issues. And for me, there's this double layer of policy, almost one that's for women and one that's for the general population or the general patient. And I think that for me is also a crux that, you need to work at it at all levels simultaneously to actually effect change on the ground.
Right, so you're saying actually that having women's health per se is almost a little bit of holding us back?
Well, not that exactly, but just that it should be part of the broader conversation. And I think putting the genders against each other is also not something that's useful. I mean, there are statistics, hypertension, for example, where women seek better care more often and are better controlled. But then when you get to more serious aspects, that's when you see the crevices and the gaps. So I think that it has to work in tandem.
Yeah.
Okay. A 50-50, really.
Yeah, okay. Look, let me move to Tiffany. Tiffany, we've just been talking then about the younger generation, and you work with younger women. I'm wondering, what your reflections on what you've heard, and then tell us a bit about the work that you do, and how this all fits in, and why you wanted to concentrate on health, why that you changed that shift.
Yeah, well, I mean, first off, I wanted to touch point on the clinical and care pathways that have been spoken about, because they're so important. When I went to my doctor for a women's health issue, a female doctor, she was the first to dismiss me, and it took me going to the male partner of the practice to actually get a referral, which just, starts to show that this is really a deeply embedded issue, and it might take some generational change to start to change that landscape.
Yeah, let me interrupt. I mean, what was striking, wasn't it, about Kenneth's talk, was about the ECG.
Yeah.
It was the women were taking longer, but it was done by women.
Yeah.
So we need to really emphasise that, but please carry on.
Yeah, so I mean, the reason we decided to focus on healthcare is we started with education, but it showed that, a lot of the reasons why people aren't engaging with education properly is because of healthcare. And health is the fundamental pillar for life. Without healthcare, you can't live a decent life, you can't participate in the economy properly, and that's, why we decided to focus on healthcare.
And presumably we've heard about women as caregivers, and you're working with younger people who may be affected by mothers, grandmothers having heart attacks, having difficulties subsequently after heart attacks. Does any of your work relate to that kind of area of supporting young people through illness at home?
Yes, and I mean, in some of our local programs, we work with a lot of different local clinics in different countries, especially South America. And there's one clinic in particular in Ecuador that does fantastic work in, screening babies and supporting all sorts of, across the lifespan of women's health. But their, I'd say, least comprehensive program is in women's heart health and cardiovascular disease. And, you know, when we started doing all the reviews and said, you know, what can we do to improve this clinic, we said, you're here to make an impact, because most women in this community would never, ever have the opportunity to seek any sort of medical support. And if you aren't screening women for heart-related symptoms and can't treat them effectively, you know, this is, as we've said, and as people will continue saying, heart disease is the biggest killer for women. So in that sense, they're essentially not fulfilling their responsibilities to that community, and that comes, again, back to awareness, and hopefully this is something that through generations we'll be able to change, that heart health is the fundamental pillar for women's health. And of course, reproductive health is very important, but the women's health community needs to kind of take a bit of a look and see that, you know, women are more than their reproductive organs, as we would believe. And so women's health is also more than just reproductive organs.
I think that should be added onto the call to action, and that sounds great. Okay, thank you for that. So Tiffany touched on the economic side. Anu, can you just explain to me what McKinsey Health Institute does and what you've been doing within it as related to heart health for women?
Thank you. This is exactly what was coming to my mind when you were talking earlier. I've heard a lot about the moral imperative to look at the women's health. I haven't heard the economic price of not doing it. And at the McKinsey Health Institute, what we are doing is, so we focus on under-invested, under-researched area of health. So those span across women's health, brain health, metabolic health. And we are putting a price to it. So we are looking for creating markets where we believe there is not enough innovation or not enough investments. So in the context of women's health, I mean, all of the keynotes were incredibly exhaustive and complementary, as you said. And what we've done, and I thought it was important to bring back the cardiovascular in the context of the full gap. So McKinsey Health Institute with the World Economic Forum looked at the closing the women's health gap, now closing this now probably somewhat famous $1 trillion. And out of that, almost 15% is just cardiovascular. And when we look not only at the price, but at the health outcomes, 25% of the gap comes from cardiovascular diseases. So those are both gigantic, but also very actionable.
And just to completely spell that out, what you're saying is that 25% of economic productivity.
So the 11% of the economic productivity comes from cardiovascular gap. So meaning, if we were to bring the same health outcomes for women than that of men, out of the 1 trillion, 11% would be closed, meaning that women would be healthier, so they would be more productive at work, miss less work. And those, if we translate those into days of work or days spent in poor health for women, that gap equates to 7 days per woman per year. 2 of those 7 are linked to cardiovascular disease. So it's both big, but it's also actionable. And I'm going to talk a little bit more about ischemic heart disease. And I think we mentioned the clinical practice guidelines. There are actually a lot of things we know as a scientific community on different symptoms, different ways of diagnosing, different curves level, yet very often we use kind of one cutoff. We looked at clinical practice guidelines for ischemic heart disease. And ischemic heart disease is in the care delivery gap is the single biggest contributor of the care delivery gap. We looked at 15 countries globally. We looked at their clinical practice guidelines. While many medical associations know exactly what to do and publish what to do, European Society of Cardiology, AHA, you name them, countries actually don't apply those clinical, like updated clinical practice guidelines. We rank them from 0 to 3, 3 being all best practice across diagnostics, prevention, and treatment. And they scored across 15 countries 0.9. So it means that although there is a whole lot we know about women-specific manifestation and cutoffs, we actually don't scale really what works.
So, I mean, I know we've been talking a lot at the World Heart Summit about national heart plans, national cardiovascular heart plans. And I think what I'm hearing is that there needs to be a women's element within those plans to actually action. I don't even know. Does anyone know whether the Safe Heart plan has got a women's specific component within it? Anyone know? No? Anyway, it's worth looking into. But okay, thank you for that, Anouk. Okay, so let me move on to, from your organisational perspectives, what's being done. I'll come back to you, Alia. I mean, what's the WHO? Is this something that WHO is actually, working on, keen on, pressing on? Obviously you've got this department, right? It's got a great sounding title,
Doesn't it?
Yeah.
So, well, it's actually changed. Don't get caught up on that
No.
title
What,
because
so
of
did
our
I read out
restructuring.
did I read out the
It's,
wrong one?
Yes,
Oh.
but it's because of our restructuring. It's not a problem. So it's
Okay.
the gender rights, equity, and sexual misconduct prevention. That's because we've merged two departments
Okay,
together.
right.
So
there's been a lot of changes at the
yes,
WHO.
there's been a lot of
obviously.
changes.
Yeah. So
But
tell me what you're doing to try and
Okay.
plug some of these gaps or persuade countries to do. I mean, how does that actually work? How much power do you have to exact change in this?
Okay, so WHO is a massive organization, but I think one of the things that we're trying to do in our department is really very much focused on looking internally as well as WHO, how we are changing the way we work to enable this larger change. So that is actually a critical piece in terms of inward looking. And we do have a women's health coordination mechanism so that we are able to define women's health in a way that is meaningful, that does go beyond seeing women just in their reproductive role, and understand that actually we have to question ourselves. Are we recreating those biases because we all carry these norms and these biases with us wherever we go? So it's a different way of approaching the work. So it's more of a coordination and getting those experts in their areas. So we do have our colleagues who work on non-communicable diseases as part of that. We have our science division also as part of that to tackle the research agenda.
So hold on, so just so I'm clear. So what you're saying is it's not siloed. So you've got somebody trying to bring in someone from the NCD department into your department so that you're working together. Yeah.
So
rather than having somebody within your department
exactly
responsible for NCDs.
We don't see ourselves as a vertical department. It's called an enabling function. We're supposed to enable others to take on this work within their expert area. We are not expected to be experts in all of the areas that require attention, but we are the catalysts and the drivers across the organization.
How many people are in the department?
We're about 10 people,
Okay.
so it's a smaller department, but it's sitting in the office of the Director General, and so kind of signaling the leadership commitment to this area. But we also see ourselves as enabling country-level impact, and so support to member states is important, and we want to partner with those ministries of health. Partnerships with ministries of health is absolutely critical. We recognize that some ministries of health want to do more in this area. And so we are facilitating that by looking at partnering. So we have 36 countries that have signed up to look at issues of gender rights, equity in national laws, policies, plans, strategies.
Right, so those 36, is there any kind of common factor as to why you think they may have signed up? I mean, we know there's a lot more nations than 36, right? But are these the nations that you want to, who you think there might be the most inequity? Or is it the usual suspects who are ahead of the game anyway? I'm thinking Scandinavia.
No, it's not the usual suspects at all. Right. Actually, they surprised us. We were targeting, and the reason we did this was we wanted to be able to trace whether we are having an impact or not. So we call them tracer countries. So we are going to accompany them from the beginning until the end to see if our tools and guidance is actually having an impact, but we have to build it on what they want to do. So they've opted in, and it's not the usual suspects. We were targeting 12, 36 have opted in. So that's actually a really positive sign. All regions, all of our WHO regions.
I'd love to talk to you more about that in my other life. So okay. Taskin, let me come on to you. So you're an advisor and voice for the World Heart Federation. I think you're a member of the advocacy committee.
Yes.
So I want to, we've moved now to solutions, right? I think it's really important in this debate to concentrate on what we can do, what needs to happen. I mean, of course, we've got Barrett's lovely call to action there, which does cover an awful lot. But from your perspective, what are the urgent priorities for advancing action, and what would you define as success from a World Heart Federation point of view? going forward? If we were here in 5 years' time, what would you want to have achieved, and how are you going to do it?
So there's a few things, and coming back to your question about strategies, so I had a quick look at which countries actually have women's health strategies, and Ireland, Australia, and I think it's the UK. So really, that's specific strategies at a national level. So it gives you some idea about policies.
But can I just give you a top shout out to one of my peers in Rosie Taylor, great campaigning freelance journalist. She did a report, I think it was last week, which showed that we're spending more money on men's health than the women's health strategy. So we may have this lovely strategy, but actually whether it's funded is, so I'm...
Exactly. And far be me to call for more strategies anywhere. But it does give you an idea of which countries are thinking about it and which countries are moving forward. Obviously, you can't have a strategy for everything. And I personally feel that since women are half of the population, you're not a key population.
No.
You have in some diseases key populations. When women are half the population, if something is not working, it's not working, period. It's not working for this or that. So I think that's pretty important for me. And I think in general, we don't need general advocacy anymore. It's quite clear that we've tried to do advocacy, we've done advocacy, but what we actually need is a few targeted pressure, where decisions are actually made. And I think there are, for me, 3 priorities. Firstly, I think it's been spoken about quite a bit. It's about disaggregating data and making sure that the sex is, properly reflected. And it's quite simple. And the second would be about research funding. So a lot of research doesn't prioritize women's cardiovascular health or women's health in general, and the system wouldn't move. But there is an initiative from Wellcome and LEAP and pivotal ventures getting together and really targeting cardiovascular health as well. And that for me is quite a lovely traction, in this area. And the third would be to embed it in national policy frameworks, not have it as side initiatives. And I do think that's because, in women's health programs, rather than in core disease strategies, you see it, you see it labeled as women's health. And for me, what success would be like is not to have more reports. Although my day job involves, creating and developing a lot of reports, it's actually when the clinical guidelines will change, when the practitioner behaves differently at the first point of care, and when we stop being misdiagnosed as women, in settings. I think also women's groups tend to talk a lot to other women. This as well has to change because it's often men dictating what goes on. And unless you have really progressive men, and for me it's a personal story. So I'm South African, and for me I never grew up with any gender bias because my grandfather was extremely progressive. So I never saw him treat his son any differently to his daughters, and so that wasn't a mechanism for me. But it took my grandfather, being the matriarch, to prop up my grandmother to actually carry on this legacy. And I think that that's important, that when we have conversations, that men are equally part of the conversation and part of the solution.
Absolutely. I think it's important not to push away men, and they're thinking that actually that they are being rejected and aren't part of it. And if you could come in and also tell me what you think is some of the key solutions.
No, and I love what you just said, because I think there is an element of language, and we know how important language is. We talk about these atypical symptoms for half of the population. What I found also, sometimes also there are 2 things with the word women's health. First, kind of this implicit reduction to sexual and reproductive health. Although we do big efforts to broaden the definition, it still doesn't come necessarily naturally beyond a certain kind of circle or echo chamber. And I found actually the concept of sex disaggregation or sex appropriate care sometimes better resonates, because in our research, in 2/3 of the cases, we see that women are kind of, we will call it disadvantaged, be it either the gap comes from efficacy or effectiveness or health intervention, so drugs or surgery will be less efficacious on a women body than a male body, and we know why, because they've been tested on more on men, etc. Or women have less access to care, so once they enter in the health systems, there are biases such as to give them less access to those health interventions. So in 2/3 of the cases, women are disadvantaged, but in 10% of the cases, men are disadvantaged. So for us, it was also a very important realization to say, in only 20% of the cases, at best, men and women react the same to health treatment or systems, and yet we treat women as if they were a small version of men. So this kind of concept of sex-based differences and sex-appropriate care sometimes also resonate better in conversations. And how do we embed those early on in trainings, in medical curricula? How do we embed them in clinical practice guidelines so every single doctor on this planet has access to the latest and greatest knowledge on those?
Sure, and I think, obviously we've talked about, Amanda talked about the 38% of people being participants in clinical trials, and I think we haven't discussed yet how do we change the, is it the criteria or whatever it's the technical term for companies, to actually get women onto trials more. So we've got that evidence base more, and how do we increase the amount of research funding in these areas too? I mean, do we have any solutions to that? I mean, the clinical trials it's a big question. Who can take that on?
I have two hypotheses on the clinical, and we know for women, it's very difficult to get women on particularly cardiovascular clinical trials. I mean, on one hand, and we've heard it from big pharma running those clinical trials, they discovered that women were at the wrong specialty. So because of the symptoms are so different, that there's nausea involved, fatigue, women are at the gastroenterologist or the immunologist, so they're not at the cardiologist. So there is a bit of like, how do we rethink those care pathways so that we catch women at the right recruitment?
Because they're in the wrong
specialty. And then those also cut over like those inclusion-exclusion criteria. If there is a single cutoff for women, very often the curves of women and men don't perfectly overlap. They are a little bit separated. So putting one single cutoffs by essence actually reduce the size of the population of women. So thinking again through the lens of sex-specific criteria and sex-specific pathways is probably part of the answers on how we can get more women into those clinical trials.
Yeah. I know you're not technically on the panel, but if you did want to come in, Barrett, about how we can get more women into cardiovascular clinical trials, please do. But have a think about it if you want to mention anything. Tiffany, let me come back to you. In terms of solutions, both advocacy and practical solutions, what do you think needs to happen to address some of the issues that you mentioned earlier?
So just even a few weeks ago, we held a meeting in the UK Houses of Parliament, and of course invited the World Heart Federation, who really brought that cardiovascular disease perspective and started to look at what some of these solutions have to be. And we came up with the beginning point has to be regulation in healthcare and women's healthcare, because there are so many incredible companies who are creating great products, tests, treatments, diagnostic tools, but regulation continues to be such a big barrier.
Sorry, what do you mean regulation in what sense?
The regulatory bodies across all the different
you mean
countries.
the medicines regulators?
Yes,
like EMA,
regulators.
MHRA.
Yeah, and all of the different FDA, EMA, AMA.
And how are they preventing? What are they doing to hinder women's health?
In their eyes, they would say they're not preventing innovation, and they're just trying to make sure that it happens safely. But it does end up becoming such a process, especially if, imagine you're a really small organization and you've created something like a test for endometriosis, which, we spoke to an organization who had done that sort of thing, or wanted to get more women into, clinical trials for heart disease. And there's just so many expensive barriers. And then let's say you get it passed through the UK MHRA, what then happens when you want to go to the US and you want
Yeah.
to go into Africa and you want to go to the rest of Europe, it becomes such a long process, and it is actually stopping a lot of people from wanting to create innovation.
Right.
And that becomes a really big issue in something like cardiovascular health for women, because essentially we're going to have to completely relook at all the medications that women are taking for cardiovascular disease, because if they weren't included in the clinical trials, then, you know, what's the next steps to that? So regulation has to be the first step, and then innovation, of course, and supporting the different groups doing that. So Welcome Leap, as you mentioned, were a part of that as well. And then access, because what is the point of creating these amazing medications, getting them approved through regulatory hurdles, which is a long process, and then it's not accessible to women who need them? So those are the three kind of stages we're looking at it.
Sure. I'm going to open the session to questions in a minute, but just to finish off some of the arguments that we were talking about in terms of, you know, medical education. And I just suppose to anyone on the panel, you know, obviously what comes across loud and clear from Kenneth and from Barrett is we need to educate doctors on the ground so that they are proactively thinking about these potential symptoms in women, so that women are not rushed, that's the wrong word, but are put through the appropriate pathways at the right time in a timely manner. And also that women are themselves not only looking out for symptoms, but also are acting on them, because, you know, they may have you talked about self-care?
Yeah.
It's not happening, right? So what are the solutions to those two elements of changing the medical mindset and also encouraging people to look out for themselves? Who wants to take that?
It starts with redesign, I think. You know, redesign not only of the medical curriculum, but coming back to your question on the clinical trials, they also require redesign, because it is, you know, some of it is the sort of eligibility criteria that you spoke to, Anu, but then it's also that study designs don't account for life course realities and what women are doing and what, you know, other responsibilities are happening and participation. But once you have that, and then if you can think through, you know, making the medical curriculum, I mean, medical curriculum requires a revamp in general, so that's no argument. But you've also got to teach these kinds of, you know, pathogenesis and pathophysiologies from the ground up, I think. And just, I think, make people more aware of the symptoms and how people present.
Yeah, okay. I've got a bit rogue with some of my questions. So, are there any points that people want to make that I haven't addressed? Ilya, anything you want to say?
No, I mean, I think building on this,
Yeah.
and thinking, you know, reflecting, WHO has this mandate, and it's a massive mandate, and it is, you know, setting the normative standards, and it is really driven by evidence, you know, evidence-based policy making, etc. But if there's a problem in the data and the evidence that you're generating, so you really, I think that you really need to target that at the beginning, because that's going to drive the change. Because if it is about you know, talking about a rights-based agenda, that's not what's going to actually gain the traction. You need to work within the system, how the system is functioning, and help it to change. So, you know, I think there are, as WHO, we haven't operationalized yet, but we signed up to the Sex and Gender Equity in Research Guidelines, and there's other initiatives like Message, which are also similar. So really pushing that, driving for that, where there are sex-related differences, to make sure that that is embedded right at the beginning, in the design, in the recruitment, in the analysis, in the reporting, throughout the cycle.
I mean, that sounds to me, it should be straightforward, it should be easy to do. Okay. So we need to target the guys that are responsible for clinical trial design overall in terms of who would that be?
But I think that's also where, you know, WHO does play a role.
Yeah, okay.
And that's why we want to, you have to model it yourself before issuing that guidance. So the intent is there. We are in the process of operationalizing.
Okay, let's open the floor to questions. Yes, please, Jackie. You say who you, I know who you are, but you say who you are to everyone.
Yes, so thank you.
Yeah, it's on.
Okay, thank you. This is Jackie Malouf from Lebanon, Vice President with the International Diabetes Federation and on the board of NCD Alliance. So I almost want to say, thank God for gestational diabetes. It only happens to us. Yay!
Yeah.
So, yeah, okay. So other than that, I want to say, build on something you mentioned about women being slow. I had the pleasure of participating with the American University of Beirut in literature review and meta-analysis about why diabetes affects women a bit more than men regarding the complications. And I was shocked to see that the main reason was the issue you mentioned, which is women neglect sometimes self-care. But why? To take care of their families. They don't go to their own appointments, but they go to their children's appointments, to their husband's appointments. So, and then other things were mentioned that make me say that this is further than women's health. It's about women empowerment somehow. So what about joining efforts with other bodies, not purely related to health, in order to empower these women who don't know what their rights are, who don't know how to do self-care, who might feel guilty if they do the self-care, not knowing that if they are okay, the whole family is okay. So please enlighten us. And thank you for the valuable talks.
Sure. Thank you. So I'm going to ask Tiffany and Taskeen on this, because you mentioned about the lack of self-care, and you mentioned about the changes in the current generation, and maybe you can learn from them and tell us how we can persuade. Was it Alia? Actually, sorry.
It's all right.
We've had a lot of conversation. Whether or not their mothers and grandmothers can learn from those younger people. So let me come to you first of all. Then, how do we do it?
I think that was one of the points I wanted to make.
Yeah.
You know, the last World Conference on Women happened in Beijing over 30 years ago. Women and health was one of the 12 areas of concern, but it has slowly fallen off the agenda of gender equality advocates. And I fully agree that you need to bring this back together. And we need to bring health into the gender equality agenda. We're bringing gender into the health agenda, but health is not really covered adequately in the gender equality. So fully agree. And I think that we need to do this more.
Okay. Thank you, Alia. Tiffany, how can we get the mothers and grandmothers to make sure they go to their own appointments and prioritise their health, not just their children's?
I think part of that comes down to finding, different sort of advocates within each community, and, making sure that they're talking about these sort of issues, as well as really looking at the integration of all these different areas of women's empowerment. We chose health, education, economic empowerment, and violence prevention because we think that each of them are completely interlinked. And health and education are obviously the two most similar, most easy to link. But then all the way to, violence prevention, if we're trying to help a woman who is in a very difficult situation or an area of a lot of conflict, she is not going to have the time to even start talking about early prevention, intervention, let alone diagnosis and treatment for cardiovascular disease or any sort of women's health condition.
So it's a complex web, isn't it, of sorting out all these different elements within society that affect women, which may be preventing them from going to treat themselves. Yeah. I've got, this is hands up. I'm going for the quickest hands up, right? Gentlemen, And then, yeah.
She pushed me.
Okay.
She was like,
Sorry.
Sometimes people walk away with a lot of knowledge, information. This journey I experienced with my own mom, and I represent Dubai, UAE.
Okay.
And that's not a problem of state of art or finance, private insurance. And I had to spend, first of all, a month to move her from GP to a cardiologist. And she's a typical diabetic, 10 years, 15 years hypertension. And I struggled. So I cannot even imagine what happens out there. And I'm a cardiologist as well. But that's not why I stood up right now, because I went through pushing the doctors from ER to take her to cardiac CT. And I pulled out the papers because recently cardiac CTA became class 2. And I'm like, she's covered, she's insured, I'm paying, what's your problem? Right? Move her to do a cardiac CT because I'm telling you, she's different. I had to sell the story.
Yeah.
Her symptoms are
did they
not
know that you were a
typical.
cardiologist? You said you were a
I had
cardiologist,
to
right?
at one point. It got so frustrated.
Right.
Yeah? And I was like, dude, I'm telling you. Like, I'm here standing.
Yeah, yeah.
Because she went through PCI 7 years ago. Classic case. I'm like, even if anybody who just graduated would know this is the next step, right? And I was like, you know, she's got a stent. Maybe it's restenosis. We got to move her and stuff like that. And then they're like, I'm not sure. Maybe it's a panic attack and ask her to breathe. I was like, if I went and told that to my mom, you don't know my mom.
Yeah.
And I'm like, okay, let's move her for CT. And I was surprised. The CT was also a general CT, not a cardiac CT, sitting in an ER. And I was like, okay, what? Do the cardiac CT. And they're like, yeah, we see something. I'm like, move her to intervention. So I'm here hand holding,
Yeah.
just because she's a woman. Really, it was because of a woman, being woman. And now an intervention comes in. 3 days, all this is happening in ER. And I'm like, I refuse to take her back.
Yeah. On grounds of time, I've got to ask you, what's your question for the audience,
So the
for the
question
panel?
is, so this is one topic. Now, second topic is breast cancer. And
Yeah.
you're like, this is a cardiologist where you bring in breast cancer here. It's a common take where breast cancer patients go through a lot of radiation therapy and the heart is pretty exposed to radiation. So when we're doing this cardiologist research, I mean, are we also taking breast cancer as a topic, as horizontal? Because there are women sitting there in cancer therapy, going through therapy, having heart exposed, but you don't have cardiologists in a breast cancer team.
Yeah. Okay, Taskin, I know as I said I wouldn't ask any, put any medical questions. I think that you're the person to comment on this. I mean, first to the discrimination that the mother experienced, but then this issue of other medical procedures which may give a higher risk to women.
So I think it's pretty normal, and I think many people. I saw you, Anna, nodding your head at the story. So I think it's a pretty reasonable one. But I think in terms of the cancer aspect and the multidisciplinary approach, I think increasingly people are becoming aware that different specialists within the hospital need to talk to each other.
Yeah.
And that is just flat across, men or women's health. The complexity of chronic diseases and the overlap is becoming more and more difficult to ignore. So I do think that eventually one would land up with the multidisciplinary team.
Yeah.
But I think it's also difficult in terms of system change to get there. Because we all do operate in our own little expertise. And, making that a system-wide policy and integration is difficult.
Yeah, and certainly with menopause and endocrinology, I think that's absolutely needs to be brought in. Yes, ladies waiting patiently.
So I'm Letitia van Haren, and I have an organization called Smart Access to Health for All, and it's to connect the health seekers with the health providers, starting with the most vulnerable, which are poorly educated women in rural areas when they are pregnant. So that's really the start, but we want to do a lot more. Now, from the time I hear you about the systemic changes, and you mentioned a little bit the fact that, of course, they can't come because they have to look after children, have to do 1,000 other things. It starts already with opening, being more receptive when you make an appointment that a woman may not have the exact hours that the hospital is proposing. Because when men say, but I'm the director. So, okay, everybody mobilizes and they can come at an odd time.
Yeah.
But allow the women to come with the small kids that they have to bring along.
Yeah.
If there was more, then we can later see how we can adjust the system. But let's start with that, showing that you care about what they are. Another thing is, I would like to know who gets cardiovascular disease among men and women. Is it the women more anxiety, stress, and overwork? And is it the man more laid back, bad health habits, bad food habits? But the woman is always alert. In my family, I don't know how many men were saved when they had cerebral something or, cardiovascular. Because even if their wife is reading quietly, she kind of observes, hey, you've got to go. And my brother was saved that way, another one as well.
Okay.
The two brothers who died didn't have a wife. So if we want to I'm not kidding about
Okay, no, I think we can see
But
that
what-
women are
what I
saving
mean
lives.
is if we want to change this, and women are going to be more involved in
Yeah.
self-care, are we going to replace her alertness towards the other members of the family by somebody
Okay.
else being more alert?
Okay,
That's
okay.
important.
Another
So-
reason to have a wife.
Exactly. So yes, does anyone want to reflect on how we can transform health services so that they are more accessible for women at all times? Someone was talking at the summit last week about better ability for childcare for women to enable them to have appointments. And that men have more acute incidents and make more fuss about it, and it gets acted on. Does anyone want to comment on that before we go to some more questions? I think it's very eloquently put. Boriana, I think you have a question. Yeah.
Thank you, amazing panel. My question is half a question, half a cry for help, and maybe also 3, and 1/3 of brainstorming.
Okay.
with all of the panelists. Going back to our meeting in London at the Houses of Parliament, we did speak about fast tracking. In that case, it was medication and innovations. But we also used the example of COVID and how the urgency of COVID made fast tracking possible. And then we talked a lot about how do you galvanize that urgency for women, for health. We talked about women's health in general, not only cardiovascular, but obviously every other disease was there represented, and cardiovascular sadly is the #1 contributor to that statistic. So we did speak, and there was a lot of mobilization, especially amongst younger women and men, who said and gave us statistics about the urgency of the problem and how it should be understood as an urgency. They compared this to the climate urgency, and it's in our faces. And if it concerns half of the population, what can we do about it together as a movement? So the call to action is not just we go back. Of course, we are obliged to go back to our daily jobs and and think about what our specific role in the organization, but working, just every single word I heard here, if that can be built into this narrative of urgency together, and we can commit to something maybe focused, very focused. Is it access? What is the focus of something that we can really fast track and use it as a platform? And also even a question to you, Jackie, as a journalist, how can this notion of urgency be communicated in the best way if it concerns half of the world's population?
Sure, okay. Well, I'll have a little think about that while my panel are answering. And I've also noticed we've actually only got 2 minutes left, so this is a kind of a last point really for all of you on how we can persuade policymakers, women themselves, men, everyone, that this is an emergency of the similarity of level to the climate change emergency. How can that be got across? So I'll just go around. Tiffany, do you want to kick off?
We're fast tracking, creating a fast track for women's health innovation, bringing together, regulatory groups from every single region, policymakers from each region, as many organisations. So everyone in this room really should be a part of that, because we have to end the silos and close the gaps for women's health. But it is important to talk about awareness too, because especially with the McKinsey report, that really was such a big catalyst for change in terms of women's health. But it seems like heart health and cardiovascular health is almost being left behind in the women's health conversation. So we need to find a way to, if you see what I mean, close that gap too, so that women's health can all be developed together.
Yeah, and the one thing that you would like, I mean, obviously we've got all those calls to action, there's a great list, but is there what's the one thing that you would want to change to advance better outcomes for women's cardiovascular health?
I would say first it is creating that fast track for women's health regulation.
Regulation, okay.
Yeah.
Anouk.
I mean, the link to the sense of urgency, I think the business case or the economic case hopefully helps speak the languages of Ministry of Finance and others. I was trying to think, I think the call to action is indeed great, and I think we all have a slightly different framework to say something similar. What I was thinking more is, for every single person of you, what is it? Can you please have this intellectual curiosity to think about, in every action you take, what is there a difference between sexes in what I'm analyzing? because it's truly a multi-sectoral, multifaceted problem that doesn't have kind of a single solution. So go back and have this intellectual rigor and curiosity to think, is there anything that looks different for men and women? And sometimes it's going to be men disadvantaged, sometimes it's going to be women. And all of us with smaller actions can make a difference.
Okay, thank you, Anouk. What about you, Alia?
Well, fully agree. On the upstream level, in the current environment, I think the economic argument with policymakers will give a sense of urgency. But I think it's at the same time, if you're out there to the general public, we really need to build coalitions, you know, amongst different, and leverage the resources and networks of each of us. And agree on the key messages, because I think, you know, like things, if we can agree on those key messages, then we can do that and leverage that, because I do think we need not just to wait for the policymakers or the researchers to change, we need to educate.
But when you say we need to agree on the key messages, who's the we? And how can that,
Whoever
how
is
can that be
working
done?
in this area. I mean, those of
Got
us
to be
who
led
are
by
in the room,
Gloriana.
exactly.
Right, okay, back to you.
Yeah.
Taskeen, let's final word from you.
So women are still being failed, not because we lack knowledge, but because we have not redesigned the system around the knowledge. And for me, there's really two things. It's about women in leadership and women being part of the designing process at the outset, not as tokens, because that's a new thing as well. You know, you're part of a token panel.
Yeah.
You, the women, tick. The Global South, tick.
Yeah,
you know.
yeah.
But are part of the architecture and the design, and therefore the expertise, more than tokenism.
Absolutely. Okay. Look, thank you for that, Taskeen. Look, it's been an amazing discussion. I've been so delighted to speak to all of you and for your questions. I'm answering your bit, right, which is, you'll have noticed when I'm moderating that you know why I love it is because you tell me things and I go, oh, right? And that's what a journalist wants. They want something that's really striking and fascinating, and that they know that their readers will have a response to. Okay, they'll have that same response. And so today, some things that you said in the panel, but also some of our audience, some of the stories. You know, your personal story, your personal story, your personal story. Those are the things that people can relate to. So I would say, build up a bank of people who are prepared to talk and get it across in those human terms. And I, you know, not just that, you know, having the summit with all of the lived experience people, Ram and Anu and all those people. So it's having their voices loud and clear. So I'm delighted that you've all taken part and contributed so much. I'd like to give a round of applause to both to our panel and to Beatrice for hosting and the World Heart Federation.
Moderator.
Thank you. And now there are drinks and lunch for those of you who can stay. We'd love you to carry on the debate. Okay, bye-bye.